Okay. After the fantastic lecture by radiological aspect of the Lisfranc injury, let me bring the orthopedic perspective, how not to miss and what are the tips and tricks. Clinically, radiologically, both combined, my 20% of the work is already being done by Harsh. So my job here will be to diagnose from a clinical to radiological point. So yeah, so thank you, Journal Club and Vidarbh Academic Group for inviting me for this excellent discussion forum on the Lisfranc, and thank you, Chandak sir. Uh, so we are all aware about the anatomy of the tarsometatarsal region. We are all aware that we have three column, medial, central, lateral. We will not go in too much of the detail, but let me bring your attention to the base of the second metatarsal, because it is the area where you get a maximum stability of the transverse arch of the foot. And the problem is, it is the area where you get a minimal motion in the gait analysis. And that's why if any plantar flexion injury or the hyperabduction injury happens, this may bring this stiff structure into sprain or may lead to injury. So Lisfranc ligament, we are all aware that this is the only stabilizing structure between the base of the first and the second column, and is one of the strongest ligament of the midfoot. So these are the anatomical pictures about the extension of the Lisfranc from the base of the second metatarsal to the medial cuneiform. So how this injury happens, we are all aware that this is the overloading in the plantar flex position, which allow the dorsal subluxation of the second metatarsal from its stiff area of the transverse arch, and this lead to the injury. Also, it is a hyperabduction of the forefoot over the midfoot, which brings which lead to the diastasis of the first and the second metatarsal, and this is labeled as a Lisfranc injury. So the problem is, many times we see such kind of the foot sprain in our OPD, but is it a relevant problem? So let me bring your attention to the two cases. What happened if we miss the gross or the subtle injuries? The problem is 20 to 30% of the injuries, they are misdiagnosed and they are maltreated, and they may lead to 50% post-traumatic arthritis. So this is not a simple injury. We should concentrate and focus on the Lisfranc region, and as equal as the other injuries we take into consideration. So here is an example of a 30-year-old guy. He had some twisting foot injury. He went to the local orthopedic surgeon. Immediate non-weight bearing X-ray was ordered, AP lateral view, and it was said that absolutely there is no problem. You can manage with the crep support or immobilization for the brief period of the time. Patient was walking for 15 days. There was continuous pain. There was a lot of swelling around the foot. They called me. We ordered the weight bearing X-ray. So they sent me the weight bearing X-ray, which was showing some problem at the base of the second metatarsal region, but otherwise from the ortho perspective it was looking okay. So he was again treated conservatively. 40 days down the line, full weight bearing X-ray, there was, now you can see there is a visible fracture at the base of the second metatarsal, and also there is a discontinuity between the tarsal and the metatarsal region. So what are these discontinuity, we will see in the later part of my presentation, but overall it looks incongruent. Associated cuboid fracture was there. So now you can suspect what is the mode of injury. So whole forefoot was abducted in its extreme position, and this was the mechanism of the injury which lead to this problem. 4 months down the line, again he was not treated, or he was not ready for the surgery, but it was finally landed up with the bad midfoot instability. You can see on this X-ray. Another patient, 30-year-old, untreated, maltreated. He was said that absolutely okay, there is no problem. Now you can look at the midfoot posture. It has dropped down, plantar and the medial deviation of the talus is there, and he has developed the planovalgus foot. He was athlete player. So he has finally landed up with the bad planovalgus flat foot deformity. So if you miss the Lisfranc, you may land up with the midfoot instability. You may get flat foot deformity, osteoarthritis 50% of the time, and the main problem is chronic foot pain. They keep coming to your OPD all the time, and they say Doctor, there is always a pain, there is always a swelling, 6 mahina ho gaya, 8 months. So, uh, so you should always try to get maximum uh, possible, uh, I mean, the diagnosis of the Lisfranc injury. Some injuries are subtle, as you can see here. It is hard to say whether it is broken or not, but some injuries are very clear. Nobody can miss, as Harsh has presented a last X-ray. Nobody can miss this injury. But subtle injuries are the area where we need to focus more on the diagnosis point of view. So, how to avoid missing the subtle injury is the part of my presentation. So, I will try to put 7 important points, and and there is nothing guaranteed in the orthopedics, but I take a guarantee. If you remember these 7 points, it is hard to miss the subtle injuries of the Lisfranc. So tip number one: never underestimate the unexplained swelling. So if there is a pain and the swelling in the midfoot region, 20 days, 30 days, 40 days down the line, and patient is keep coming to you with the lot of pain and the swelling in the midfoot, don't underestimate it. It could be a Lisfranc problem. So first clinical tip: it if it is a prolonged swelling and the pain, and is there any visible deformity in the foot on weight bearing, always suspect something is going wrong. Why the patient is not getting cure from the simple foot sprain? Tip number two: always try to look the sole of the foot, because in our clinics we sit and we just see the dorsum of the foot majority of the time. We don't see the plantar aspect of the foot. That could be the bleeding coming from the midfoot area, which has deposited in the plantar skin because of the gravity, and that give you the high suspicion of plantar ecchymosis sign, give you the high suspicion about the ligamentous instability, and this give you the idea of investigate further. This will tell you that this is not a specific sign, but this will give you the suspicion that now you have to move ahead, you have to think more of Lisfranc. Tip number three: don't forget to palpate the TMT joint, because if you see the foot as a gross and if you touch all the whole of the foot, he will tell the pain if it is a Lisfranc. But try to find out whether it is a pain which is coming from the Lisfranc joint or the other tarsal joints. Tip number four: always get done the weight bearing X-ray if you have suspicion. As you can see here, you may see nothing in the non-weight bearing X-ray, but look at here, the same patient, when you bring this on the weight bearing X-ray, you may see something obvious. As you can see here, base of the second metatarsal is broken, the lines are broken. So always try to look at this diastasis. So this is very important. A medial border of the first metatarsal should be continuous with the medial border of the medial cuneiform, and medial border of the second metatarsal should be continuous with the medial border of the middle cuneiform, and same with the on the oblique X-ray with the third and the fourth. Always, as Dr. Munut has said, always try to get a lateral view of the foot, because if there is any dorsal step up, you can see in lateral view only. So weight bearing X-ray is very important. Flex sign, as Harsh has already mentioned, this is one of the pathognomonic feature of the Lisfranc. Base of the second metatarsal or the fracture of the medial cuneiform is a specific sign of the Lisfranc injury. Tip number five: if you still have a confusion, always try to get a comparison with the contralateral normal X-ray. So as you can see here, this is an injured X side and this is an uninjured side. So distance between first and second metatarsal at the area of base should be 1.3 millimeter plus minus 2. If any injury more than 2 of the opposite side, if that diastasis is more than 2 of the opposite side, of the uninjured side, always suspect Lisfranc injury, because you may get confusion if you have only one film whether it is more than 2 or less than 2 but if you compare with the contralateral side, you will get more idea, no, it is broken. If you have still problem, tip number 6 is always get done the stress X-ray, but this is possible only after 15 to 20 days of the injury. So this is the pronation abduction stress X-ray. So you have to keep the hind foot stable with one hand, and you have to give the maximum abduction force to the forefoot as much as the patient can tolerate. And you have to try you have to give the hyperabduction force. So now you can see that continuity of the medial cuneiform is lost with the metatarsal. Tip number 7, if you still have a problem, send to Harsh. He will get done CT or the MRI and tell you about the exact the problem happening inside the region of the Lisfranc. Also, CT and the MRI will tell you about the associated injuries and most important associated chondral injuries, which is again a part of the Lisfranc injury. So here you can see there's an associated cuboid fracture and lot many fractures, as you can see, a fourth, fifth, fourth, third metatarsal fracture that can be missed on the plain X-ray. MRI, as we have already discussed, this is for the pure ligamentous. So these are my 7 tips: unexplained foot swelling, plantar ecchymosis, tenderness over the TMT joint, weight bearing X-ray, compare with the contralateral foot. If you have problems, stress X-ray, and final the advanced imaging. So these are the hierarchy about the diagnosing the Lisfranc injury and not to miss this grievous injury. Thank you, Chandak sir, again for this great opportunity.